Took me to places I never thought I'd like. But then I caught myself in conflicting minds, pulling me past our love and out of sight, breaking my own heart time and time again. Try but I can't move on, can't forget. I can't forget you, even though my heart is aching to, even though this time I'm starting new.
We are now ready to start. Today the Premier is joined by the two MECs, the MEC for Health, Dr. Mukherjee, and the MEC for Infrastructure, MEC Mutara, and then the members of the Advisory Committee, whom the Premier will introduce. And the Premier will, before we start, explain or give an outline of how today's briefing will be conducted, the number of areas that we're going to cover, and obviously, so the Premier will then come back at the end to give concluding remarks where he will touch on a number of issues which he will indicate what those issues are. So without any further waste of time, I would like to call the Premier to come and speak to you. Mr. Premier.
Thank you very much, Mr. Masebe. Good morning once more to members of the media and the people at home. We are sorry for the delay with starting this morning. We are aware that our country is bidding farewell to a legend in our country, Dr. Jonas Gwangwa. As we are doing this briefing now, we had to delay because the funeral is underway and ensure that we also pay our last respects even as we do our briefings here. I also want to say that our country and province lost another outstanding legend, a great musician from Soweto, Mama Sibongile Khumalo. Dr. Jonas Gwangwa is from Soweto. We have lost great creative minds. We convey our condolences to their families. At this point, this is how today we are going to do the briefing. The last briefing we gave, the public media briefing we gave on the pandemic in Gauteng, the state of the pandemic in Gauteng, was on the 12th of January. And on the 12th of January, we were giving very clear warnings around what the science and the evidence is saying, where the pandemic is going, the trajectory of the pandemic in Gauteng province. We depend on evidence. We have a group of scientists. These are social scientists, health scientists, data scientists who advise the Provincial Coronavirus Command Council and the Provincial Executive Council in Gauteng on how we should be responding. The group of scientists is called the Premier's COVID-19 Advisory Council. Some of them have interacted with you before, but our response, the provincial government departments, the health department is always in the front line in the fight against COVID. And all other departments, including our economic and social departments, they respond basically based on the advice we are getting. We look at what comes from the National Ministerial Advisory Council and the National Cabinet and the NCCC, but we also look at the specific circumstances and the conditions and how the pandemic is manifesting itself in Gauteng province, in the unique conditions of Gauteng province. We also look at that, and the people who help us to look at this are here today. I must also add, we look at what is taking place on the clinical front, right in our hospital wards, in our healthcare facilities. We get that, we've got insight into that. When patients are admitted, the Advisory Council on COVID-19 has been able to get feedback into what is happening, what kind of treatment works, what kind of interventions are required. So I'm glad that today, Dr. Mary Kawonga leads the advisory committee, but she is going to introduce to you some of the members of the advisory council. You will be hearing from them for the third or fourth time, but others you are hearing from them for the first time, and others are right there on the front line. They are clinicians. We will also get clinical feedback today. So after the input, the sharing of information, the evidence, the tracking of where is the pandemic in Gauteng, the numbers, the hospital admissions, but also the hotspots. How are these hotspots shifting? How are they changing? And what is the next place where we are thinking and worried the pandemic is going to move, and what interventions should be made? After all that, we will also get a presentation on the vaccine rollout in Gauteng. It's for the first time we will be sharing with you our plan on the vaccination campaign, the vaccination program. All of you heard from the minister when the vaccine is arriving. All of you know the different phases, but the acting HOD of health, Mr. Malotani, is going to present this is not the final plan. Some of the areas are being fine-tuned in the next 3 days. But the approach of Gauteng province on vaccination, how many people do we want to vaccinate in the first phase? What is the infrastructure to vaccinate? What are the resources that will be deployed? How do we make sure there will be feedback in the vaccination program at all the different phases of it, starting with healthcare workers? So today you will also hear from us on the vaccination program. So that after that input, my colleagues and I, the MEC for Infrastructure and the MEC for Health, the MEC for Infrastructure will just give you a brief indication of additional beds. We said to you, we are working left, right, and center. And by the end of this month, we will have added additional beds. And I know there's been people who are saying these beds are not enough. And I am very glad that we are not responding to political parties that are trying their very best in using the pandemic. We don't want to respond to political parties. We want to deal with what the science is saying and what are the needs, infrastructure needs, and what are the additional human resources. So my colleagues today will also do that. And I want to speak to you at the end about the ongoing fight against corruption. I want to speak to you about that, including issues pertaining to education, issues, the allegations that are being made pertaining to myself. I'll talk to you about that. The most critical thing is for the people of Gauteng to understand, where is the pandemic now? What does this suggest Is it time to lift the alcohol prohibitions on the sale of alcohol? Some of the questions the scientists are going to help us to answer are those. What will be the impact? Is it time to lower the guard again? Is this the time? The scientists will help us deal with those issues. And the provincial government is guided by science. We don't always meet the full expectations of our advisory committee, but we try. When they say to us, this is where you must go, help here, help there, improve facilities here. Our existing facilities, we're not coping with staffing. The provincial government, so the MEC will talk about those issues pertaining to additional staff, and that's the MEC for Health. So I would like to ask Dr. Mary Kaunga, the chair of the Gauteng Premier's COVID-19 Advisory Council. She starts the conversation with the public after introducing the team about what are the trends at the moment, and she'll indicate who will follow. And I am looking forward to hearing from Professor Mayer, who is in the front line, right in the wards, in the hospitals, in the wards, looking at what is happening and what needs to be done about that, and how have they been handling the pandemic as the clinicians and our healthcare workers who are in the front line. I want to thank the team in advance for the amazing work you have been doing. Dr. Mary Kaunga, over to you.
Thank you, Premier, for that introduction, and good morning to members of the media and everyone in the room today and online. So as the Premier mentioned, the Premier's Advisory Committee on COVID-19 is here to share some insights on some of the work we've been doing and some of the insights we've been deriving from the data that we've been looking at in terms of the pandemic. Just in terms of the structure of our presentation, we're going to look at two main aspects of the pandemic. So the first aspect, we'll be looking at the pandemic at a population level. So I'm going to start the talk by just giving an overview of where we are in Gauteng in terms of COVID-19 pandemic based on the surveillance indicators that we've been monitoring. And in addition to that, at the population level, Prof. Melado is going to come after me. And Prof. Melado is a professor of physics at Wits University. You're probably all familiar with him. He's presented here before. He has extensive experience in mathematical modeling, and he's been applying that experience along with his team at WITS and working with the Premier's Advisory Committee to provide guidance to the Premier and his Command Council. And then the second, after Prof. Melado has spoken, he'll speak about the hotspots and what's happening with the hotspots in Gauteng. And that will end sort of the population level assessment of the pandemic. And then after that, we're going to have a talk that sort of looks at a lower level, which is an important level, the clinical level. So we'll be looking at the pandemic from the aspect of clinical care and provision of clinical care at the facility level. And in this case, it's at the hospital level. So Prof. Mervyn Mer was going to give that talk, and he's a professor, a specialist in pulmonology and critical care at the Charlotte Bacheke Johannesburg Academic Hospital, and he's also academic head of critical care at Wits University. So, so he's going to speak at in terms of the clinical level of care. So I will start, Prof. Melado will come, and then I'll finish on the population level, and then we'll invite Prof. Mer to come and talk about the clinical care before we hand back to you, Premier. Thanks very much. I'm going to now start this is it? Okay. So the things that we've been monitoring in terms of the status of COVID-19 in Gauteng, I'll present on just 4 key indicators that are recommended and thought important for us to monitor, and that's cases, new cases, test positivity, hospitalization rate, and deaths. So in terms of the cases, this slide here is really just showing us where we are currently, where we've been. As you can see, we've just gone through a second wave of the pandemic. And if you look at the red circle, it's highlighting that in the last couple of weeks or so, we've seen a reduction. As Premier mentioned, early in January, we were all looking at an exponential increase in the number of cases. The number of cases peaked at about 6,900 in the week of 8th of January. And since about the 12th, we've seen a reduction in cases. However, what we're noticing is the numbers are still high. They're still above 1,000 cases a day. And if you look at the graph at the bottom, it's showing the patterns of cumulative cases, recoveries at the top in green and orange. If you look at the bottom where it's circled in red, the curve that's brown, that's showing the active cases. And you can see that the number of active cases increased and peaked at around in the week of 8th of January, and we've started seeing a reduction. So this is telling us that, we're beginning to see a decline. And we think that probably the number of cases went up quite a lot during December and early January because of the festive season, increased mobility, interprovincial travel, and so on and so forth. But the introduction of public health and social measures and their enforcement in the province are probably what would attribute to this reduction in cases over the last 2 or so weeks. This is just a slide showing the details of new cases in more detail, and it's looking at week-on-week change, and that's the way we sort of monitor the pandemic. As you can see, in the week ending 9th of January, the number of cases, new cases that week were just over 35,000. But since then, we've seen a reduction over the last 2 weeks, and we're now, the week that ended 23rd of January, we were sitting at 20,000 new cases that week. That's still a high number of cases. It's about 2/3 of what they were at the peak. However, the fact that it's reduced is a welcome sign. The third indicator that we looked at is percentage test positive. So this is an important indicator, and the target that's been set by the National Department of Health is that we should see the percentage test positive go below 20% to give us an indication that we're seeing a reduction in the risk of transmission in the community. And as you can see from the graph, so this graph has 2 things in it. The bars are the number of tests done per day. And the yellow ones are the public sector, the green ones are the private sector tests. As you can see, as the second surge went up and increased, we saw an increase in testing. That's probably because there was probably a demand. People were worried about their condition. People had symptoms and showed up and they had their tests done. But since about the 12th, 13th, 14th of January, we've seen a reduction in the number of tests done. We've also seen the pattern of percentage test positive, which is the black line, and the blue one is showing the blue line is the percentage test positive, and the black one is the 7-day rolling average of the percentage test positive. As you can see, there was a peak around the 8th or 9th of January, and since then we've seen a reduction. We had actually gone as far as just over 30% percentage test positive, showing that there was a very high risk of community transmission in early January. But since then, we've seen a reduction, and we're now sitting at about 11%, which is lower than 20%. The Ministerial Advisory Committee recommends 10% as the target we should aim for. So it looks like we probably are going to be below there. We don't want to say for sure, but that seems to be where we're going. So this, again, is an indication that the pandemic is on a downward trajectory. The next indicator I want to look at is hospital admissions. And this, you can see, that's the pattern of new admissions per week. So this is a week-on-week analysis. And so the pattern of hospital admissions is actually mirroring the pattern of cases, new cases. And new hospitalizations is an important indicator because in addition to new cases, it's also showing us the extent of community transmission. And so when we start seeing hospital admissions increase, then we know that the risk of transmission is high in the community and there's a lot of viral spread going on. So again, we saw the peak in early January and we're seeing a reduction in hospital admissions. But again, the numbers of hospital admissions still remain quite high. And we just need to continue monitoring what's going to happen in the next couple of weeks or so. And the thing about hospital admissions is that because of that rapid escalation that you can see in early January, there's no pointer, the rapid escalation that you can see in early January, there was a pressure on the health system. And so people were being admitted in the hospitals. And as we all know, COVID-19 is a condition that you don't get admitted and get discharged in 2-3 days. The length of stay, people stay in hospital for quite a number of days. And so that led to pressure on the health system. And so we're currently seeing still a high number of people sitting in hospital beds, lying in hospital beds at the moment, even though we're seeing a reduction in new admissions. The next indicator I just want to look at is COVID-19 deaths. And as you can see, again, the same pattern. There was an escalation, which started in earnest from mid-December. And in the week of 16th January, we had 746 deaths that week, which exceeded the peak number of deaths we had in the first surge. In the last week that ended 23rd January, we saw a slight reduction, 5% reduction in deaths. So that's a very small dip. It's good that we've seen that reduction, but we do still need to monitor and see whether that's going to be sustained in the next week or so. So that's deaths. Now, the thing with COVID-19 deaths is, as we all know, there are probably many people who die, and we don't know that they had COVID-19 because not everyone goes for testing. And so one of the other indicators that's used to give us a measure of the extent to which deaths are happening and having an impact, COVID-19 is having an impact on deaths, is something called excess natural deaths. And the Medical Research Council has been monitoring this since last year, January. And this graph shows the excess natural deaths in Gauteng. So what the graph is showing from the red line is the COVID-19 deaths, and the blue line is the excess deaths. As you can see, there's a big gap between the COVID-19 deaths and the excess deaths. And the interpretation is that the number of excess deaths, some of those will be COVID-19 deaths, and some of those will be people who did not probably get care because of COVID-19, and the hospitals and services were all clogged up. And so they're either COVID-19 deaths or COVID-related deaths because they happened as a consequence of the pandemic. And as you can see, the excess deaths had gone down after the first surge and were more or less identical to COVID-19 deaths, but we started seeing the excess deaths increase again as the second surge happened. So that tells us that we're probably seeing more people dying from COVID-19 than are actually being recorded. So the good news that we've seen in the last 1 week is that the number of excess deaths has gone down. So last week, the week ending the 16th of January, there were 2,000 excess deaths in Gauteng, but that reduced to 1,850 in the week ending 23rd of January. Obviously, it's a very small dip, and it's something that we do need to keep monitoring. And so as the MRC releases their data and the information, we'll continue tracking that. So that's really the 4 indicators that I mentioned earlier, giving us an overview and sort of providing a context of where we are in terms of the pandemic. I'm going to now invite Prof. Bruce Malado, who's going to tell us about the work that we've been doing in terms of monitoring hotspots. And we're defining hotspots as clusters of cases. So these are localized areas where we have high numbers of cases, of COVID-19 cases, and it gives us a really good indication of community transmission. So Prof. Malado, over to you.
Thanks, Dr. Kawonga. Premier, MECs, and HOD, thanks a lot for the introduction and the grand picture given to us by Dr. Kawonga. We're now going to go deeper into the situation on the ground to assess where we are in the pandemic. I will also talk about the risk index for further resurgence, and I will close my presentation with our work on planning and modeling the vaccination rollout. Together with IBM, we have developed a tool that is public, that policymakers at all levels and the population is able to monitor on a daily basis. Currently, if you look at what's going on in the province, what's happened in the past 2 weeks is that the number of hotspots, as defined by Dr. Kawonga, has stabilized around 300 in the province, which is a good sign. That means the fact that we don't have growth in the number of hotspots indicates that we are on the downward trajectory. Although, as Dr. Kawonga indicated, you will see also in terms of the risk of a third resurgence, we are not there yet. What we can say also is that not only is the number of hotspots stabilized, but also their severity, which is extremely important to guide the policymakers and the population to understand how serious the hotspots are. So in addition to the visualization of hotspots, we provide an index of severity, meaning that that risk index gives you a measure of how dangerous the hotspot is, how fast it is growing, it's emerging with other hotspots, etc., etc., etc. What we have seen is that when you compare this week on the right to the left, and let's focus on the column that has the red frame, compared to, say, last week, we see a strong reduction of the severity of most of the hotspots in the province, which is also a good sign. That can be visualized on the map by comparing the map of Johannesburg and where the hotspots were located back on the 18th of January compared to the lower map you see on the slide, where you can see that overall the number of hotspots or active hotspots that we display on the map has stayed constant, but the most important thing is that according to the color code, that on the upper graph, which was taken, a snapshot taken about 10 days ago, there's a lot of red hotspots, whereas now those hotspots have much lighter color, meaning that the severity and the risk of those hotspots has gone down a lot, which is a clear sign that the second wave is receding. We should also look at the microscopic picture. We can zoom in and out to understand where the current hotspots are located. The upper graph gives you a snapshot of where Alexandra was on the 18th and now where Alexandra is now. The hotspots continue to be there, so we need to be concerned, although it's true that the severity has dropped when you compare the color code of the upper graph compared to the lower graph. Tembisa has been very hardly hit in the second wave. You can see there a lot of hotspots and a cluster of hotspots. That's very, very concerning. The number of hotspots has somehow decreased, but most importantly, the severity of the hotspots has also decreased there. In Soweto, you can see on the upper graph, the snapshot taken on the 18th, there was quite a number of hotspots, and by the color code, you could see they were mostly severe. Now the severity has dropped, in addition to the fact that some areas have seen those hotspots disappear, meaning that the hotspots are no longer active. They're not gaining new positive cases. So that's also a positive sign. Now, let's talk about where we are. We get the question of where are we in the pandemic? Are we there yet? And in order to have an objective answer to that question, we need to look at the mathematics that underlies all these numbers. For that, we developed for the province and the country a risk index that gives you a measure of the danger or the probability of a future resurgence. And we have to, right now, look at those numbers to assess where we are. And as the Premier indicated, we are not there yet. And let's look at the numbers. So this graph here gives you the risk index for the 5 districts of Gauteng, Johannesburg, Ekurhuleni, City Bank, Tshwane, and the West Rand, where you can see different districts behave differently as a function of time, but you can see that every district right now still has a relatively high risk index above 10. We define a manageable index or manageable probability for a third surge to be below 10. And we are still not there yet. It's true that the tendency is to level off and drop below that mark, but we're not there yet. We can go deeper into the sub-districts. The upper graph gives you Ekurhuleni, the middle one, Johannesburg, and the third one, Tshwane, where you can see that different districts behave differently. There's different demographics in different districts, and you can see that in, for instance, Johannesburg, some districts are already approaching the threshold of high risk, going below it, but some of them haven't reached that point yet. And the community, Gauteng is a big community. And as a result of that, we really have to wait for most of the numbers to go below 10 before we can say that the risk for a third resurgence is low. And this is an example from Spain that gives you a feeling of how dangerous the situation is when the numbers don't go down enough. So you see the history of the pandemic in Spain. You have the first wave there. The numbers were brought down very low, and they gave a respite to the system. The second wave came in, and as you can see, at the end of the second wave, the numbers were not brought down low enough. The risk index was very high for that country, and the third wave came in almost right away. So it's extremely important to keep an eye on this, because the probability of a third resurgence or a third wave can be very high if the numbers are not low enough. All right, so this brings me to the last topic I wanted to talk about, is the fact that we as a committee want to be proactive in modeling the rollout of the vaccine. That now this is becoming a very important aspect of our ability to control the pandemic, is to roll out vaccination. So as you know, the vaccination will go in phases. The first phase will pertain to frontline workers, and then phase 2 will start rolling out the vaccine to the population. It is extremely important to understand, in the context of the province, what is the best way to maximize the effect of vaccination so as to reduce as much as possible the probability of severe disease and mortality. For that, we use artificial intelligence that leads us to smart algorithms. So we already have the first smart algorithms that are being rolled out and communicated to stakeholders in the province. And this graph, I'm going to go through it carefully, gives you the performance of the smart algorithms. So this graph here is composed of two axes. The first axis, the horizontal axis, is the fraction of the Gauteng population that's vaccinated. On the left is 0, no vaccination. On the right is 1, complete vaccination of the population. On the vertical axis, you have the reduction of severe disease. 0 means no reduction. 1 means complete reduction. So if we follow a smart algorithm that selects, that prioritizes which sections of the population that are more prone to severe disease, to vaccinate them first, of course, that will be a strong function of age and comorbidities. You have a figure of merit on the graph there, which is the performance of the algorithm in the blue line, that if you follow smart algorithms that are derived from artificial intelligence, with about 20% of the population vaccinated, as long as we vaccinate first the sections of the population that are more prone, that have a higher probability of acquiring severe disease, we can suppress the probability of severe disease by 80% or a factor of 5. So it's clear that we have to embed intelligence into our rollout program that takes into account the numbers of Gauteng. And I should bring to the fore the fact that these algorithms are trained on data from the Gauteng province, multidimensional data provided by the Department of Health of Gauteng and the GCRO, which are representative of the demographics and the comorbidities that people have in the province. So that brings me to the end, and I will give the floor back to Dr. Kawonga to wrap up. Thank you very much.
Thank you, Prof. Melado. So just to conclude this section of our briefing on the population, the pandemic at a population level, I'm just going to give a few concluding remarks. So what does this all mean? We've given you a presentation on the pandemic, with indicators. We've looked at the hotspots and the risk index. So, I mean, the first conclusion, obviously, is that the indications are that the COVID-19 pandemic has peaked and is on a downward trajectory. And we sort of attribute a lot of this to what's happened in terms of the early implementation of level 3 public health and social measures. Just at a time when the numbers were going up, the level 3, adjusted level 3 was implemented and it's been enforced, and that's probably contributed to quite a lot of the reduction that we've seen. So as much as this is good news, we're cautiously optimistic because the second wave is not over yet. We're still seeing a high number of cases, high number of deaths, and excess deaths are still high, even though we saw an early dip. And so we need to continue monitoring very closely, particularly the excess deaths in the next week or two. And so that we can confirm that the trajectory has been sustained and gone down to low enough numbers before further decisions can be made about adjusting public health and social measures. The second thing is just to really say that given that conclusion that we've made, we must remain vigilant. And so the public health and social measures, the adjusted level 3, need to continue. We're still at a point where we feel we have to monitor the pandemic closely and really monitor all the indicators that I mentioned earlier. And obviously the population, all of us, will have to continue avoiding crowds, close contact, confined spaces. So the 3 C's mantra continues, and it's absolutely essential because there's still many people in the population who remain susceptible. We believe that's the case in this regard. And then finally, the impending vaccine rollout is good news because I think the vaccine is our best chance of suppressing the pandemic and getting out of lockdown. However, it will be a while before we reach herd immunity. That's the reality. So even if we receive vaccine on Monday, that vaccine will be rolled out first to health workers, and once all the health workers are covered, then the rest of the at-risk populations, and then the rest of the population. That will take a while. So we just want to encourage everyone out there to continue applying the public health and the non-pharmaceutical interventions. The 3 C's remain our mantra. Avoiding crowds, avoiding close contact, and avoiding confined spaces. And it's about also interacting socially, but in a safe way. So when we're meeting friends who are from different households, when we're meeting family members who are from different households, mask wearing, hand hygiene, physical distancing must continue until we get to a point where we reach herd immunity. Then maybe we can breathe a sigh of relief. So I think that's our main concluding message from this section of the presentation from the PAC. Before Premier comes back, I'd like to then invite Prof. Mervyn Mer to come and give his presentation. As I mentioned earlier, Prof. Mer has extensive experience in critical care. He's been at the forefront of the COVID-19 fight at the level of patient interaction, and so he's going to give us some of his insights from that experience. Prof. Mer?
Everyone. Good morning, Premier, MEC, HOD, and distinguished guests, and thanks very much, Dr. Kawunga, for your very kind introduction. In fact, it's a real pleasure to be here this morning. It's one of the few mornings in the last 11 months that I've actually been out of the hospital setting. And it's wonderful to hear where we are moving to in terms of the context of the pandemic in the province. But I think what's really relevant is to share a couple of lessons that we've learned on the ground in the last 11 months. And these are the issues that often get forgotten, the human elements. As someone who is a clinician scientist, I love the human element of what we have to deal with every day, because that's what all of us as decent human beings resonate with. So I'm going to take a couple of minutes of your time and just share with you a couple of the lessons that we've in fact learned from a clinical perspective, how we've tried to arrange things, how we've tried to move forward to try and provide a service to severely ill patients such that they could have the best potential outcome. I'm going to look at a couple of issues. I'm going to run through what the last 11 months has truly meant to us. I'm going to chat very briefly about the preparation and the relevance of that, the importance of communication, how we address staff protection, and how we in fact took an enormously challenging circumstance and tried to create an opportunity from it, and how we should never forget that simplicity is what we should all focus on. It really is the ultimate sophistication, why it's important to be flexible, what it means to be in this healthcare profession, what critical care is all about, and then I want to touch on two issues that I hope will resonate with you very significantly in terms of what I refer to as difference, and then we will conclude in a way that is normally not the issue in these sort of fora. So if someone said to me, what has the last several months been like on the ground? And I can honestly say I've been in the hospital every day and every night for the last 11 months. And as someone who enjoys wordplay and sharing of entities that may resonate with individuals, I would say it's both been taxing and tantalizing, eerie, scary and enthusing, intrusive and illuminating. We've learnt a fortune, demanding and distinctive across a variety of spectra. But at the same time, it's been rewarding, and anything that anyone has been through in any context requires reflection. And we've had to reflect significantly on this. And as a consequence, multiple lessons have been learned from the challenges of COVID-19. And our scenario is a very different one to those that panned out and rolled out in other domains around the world. We are a resource-limited country. We have to remember that 55% of South Africans live on under 30 rands per day. Prior to this pandemic, 16 million South Africans traveled every day in minibus taxis. And that's the scenario that we face. We have around about 12 to 50, for every 12 to 15,000 citizens, one doctor. In the USA, it's one doctor for every 375 people. In Europe, and I've done the calculations, having to share it recently in an international forum, one doctor for around about 400 people. Our scenario is entirely different, and we need to have borne that in mind. And that is why I want to share some of the issues with you today, to really give you insights in terms of what has happened. And recognizing that background, we realized that preparation was pivotal on the ground. And we had the gift of time, because when we started getting reports from China in January last year, just about a year ago, we were quite concerned that this could in fact evolve into a global pandemic. And that was based on some of our own work in South Africa, in Gauteng, at our own hospital at Charlotte, where we are a referral center for so-called viral hemorrhagic fevers. And so literally from that time, we got a team together with all the relevant clinical disciplines, infectious diseases, internal medicine, the laboratory people, security, the nursing staff, critical care individuals, and everyone whom we deemed would be relevant. And after our first meeting that we called, we already had a protocol. We already had a protocol in place that in fact was later refined and widely adopted, not just in this province, but around country. And so preparation, enormously relevant. The second important lesson to have taken out, and something that is an entity that we all need to emphasize, communication. Communication was absolutely paramount and still remains paramount. We, in fact, engaged with all the relevant role players across all the disciplines, and was constructive engagement, polite engagement, and inclusive engagement. And in fact, I have to commend the Premier and many around for allowing us the opportunity for that to evolve and take place. Because right at the outset, and many of you would identify significantly with this, there was enormous fear, there was enormous panic, there was enormous anxiety. And so what I introduced in our setting and in our unit, and this has evolved to many other units in this province, we had a daily feedback meeting where everyone had a voice. We did the same thing at night because there are night staff. And this was very labor intensive, but it allowed for fears, for expression of anxiety, for expression of elements that people were concerned about, and everyone was heard. And as a consequence, we were able to address the vast bulk of those issues. And where decisions had to be made at a higher level, it made it a lot easier to implement them, and everyone then bought in. We addressed all the issues openly with respect and tolerance, which is the way that we should be going about things in any scenario. And as a consequence, the very people who didn't want to go to the forefront and deal with this eventually felt backed and appreciated. We had passion and purpose, and I can tell you that as a consequence of this, people in fact committed themselves to this cause, and where people were wanting to veer away from it, we even had people volunteering to actually come and get involved. In terms of communication, it's not just with staff and the people in the context. And this, again, is across the spectrum, healthcare workers to security people to our administrators. We made sure that no patients in our setting, and we've tried to share this everywhere else, the families who could not come and visit severely ill patients were kept in the loop. We originally initiated, and we had a few donations of cell phones so that we could get some of our patients who could speak to their families, and where that wasn't the case, we could communicate with them daily. The human element, so relevant. Staff protection was absolutely paramount. We'd heard about the elements, and because of the fear, the anxiety, and the potential for this hugely contagious disease to be there, and we know what the impact has been. Many of our own colleagues, unfortunately, have contracted the virus, and some of them very sadly have succumbed to it. And we wanted to make sure that our staff were absolutely protected. There are national guidelines, there are NICD guidelines, and in fact, we initiated our own training such that we could instill a degree of confidence on every single healthcare worker. And in fact, what we advocated has now been widely adopted, not just in this province, but in the country. We in fact went beyond some elements that the World Health Organization was addressing because we felt there may have been some voids or deficits. And that, since we introduced that, there have been very few healthcare workers in our setting who've in fact contracted the virus. And this was exemplified by reinforcing very important infection control measures, some of them very eloquently alluded to by Dr. Kawunga. And we have overcome the challenges. All those initial PPE entities up front have now been addressed. People are comfortable with how to go about things. And when you can induce comfort and confidence, you can go about your work in a fashion that does bring about it the passion and purpose. One of the most important things I think that this pandemic has brought to the fore is that whenever we are faced with challenges, we not only have to deal with the challenge, but we should look at opportunities as well. And so recognizing this entity very early on, we in fact thought that it would be in our best interest, in the province's best interest, in our own hospital's best interest, to maximize our own existing facilities. And the reality of where we are in South Africa, as I shared earlier on, was very important here. When we're talking of the field that I work in, critical care or intensive care medicine, we had a paucity of intensive care beds. In the whole country in South Africa, we have 70 to 80 trained intensive care specialists, only half of whom practice full-time. So we've got a country of 60 million people, and you have around about 40 and maybe 45 full-time intensivists to deal with the pandemic. And so we really engaged early up front with social responsibility partners. We had great backing from province, and we were able very quickly to double in my own facility, the critical care facility in terms of bed numbers. We engaged additional staff, just a few, 3 or 4, and we, as a consequence of that, we've in fact been able to manage the pandemic in the first surge and the second surge with most of the patients who've required in our facility critical care services. What we did at the outset became effectively a model for others, and we helped facilitate this sort of project in other areas in the province and outside of our province as well, in KZN, in the Eastern Cape, and assisted in that sort of fashion. We additionally started a nursing upskill program because it's great having a few extra doctors, but you need nurses, and they are I cannot commend the nursing staff sufficiently. And we started a program where we now have, looking after some ventilated patients in the ICU, nurses who've come from old-aged homes. And we facilitated that. We acquired ventilators and so-called CPAP devices, some of them now manufactured in South Africa at a cheap cost. And I can tell you, I think the introduction of these CPAP devices has revolutionized some of the care offered and saved countless lives. And I think what has happened as a consequence of trying to optimize these opportunities in the face of a challenge has meant that for years to come, patients in this province are going to benefit. We've probably advanced critical care 10 to 20 years in this province. And you might see the picture at the bottom right-hand corner of this particular slide, and this was part of the facility that has now happened. This is what we've got in a setting that probably could not have happened. So not everything is negative. There are positives that have emanated from this. I'm a huge protagonist of simplicity. We often make things complex, and simplicity and pragmatism and adherence to basic principles will often stand you in good stead. If you do the simple things well, most of the time you're going to have, hopefully, a favorable outcome. And in a country like South Africa, in a province like Gauteng, the one thing we can do, we may not have everything, but we have excellent clinical acumen. And so clinicians on the ground can make a huge difference in terms of how to do things, when to do things, and how best to do things. And a term that I've now coined that I know has been bandied around the globe is something that I shared right up front on an international conference. Being poor, and we don't have all the resources that everyone elsewhere does not mean poor care. And that's something that we need to bear in mind. Sound practice with excellent quality care is feasible and possible, and we can offer and have excellence in the face of adversity. So people often say, what about the story of doing more with less? We've done that. We've done that in this province, and we soon recognized that doing more with less was great, provided you didn't do less for more. So you don't stretch too much, because then you impact. And we've done that with creativity and innovation. And in fact, we've introduced elements that have been widely adopted elsewhere. We were amongst the first people globally to use corticosteroids in critically ill patients to help improve the outcomes of these patients. Long before the evidence became available to us, we were using it 3 to 4 months before, based on work done in South Africa. We don't have facilities where we have fancy negative pressure facilities to remove this virus from the air. We don't have fancy turbines in our hospital to do that. And one of the things that struck me is, but we have windows. Open the windows. And in fact, you get better air exchanges than many of those fancy facilities can offer. We did that up front. And in fact, there were wonderful lessons. You may have heard of turning patients onto their tummies to improve oxygenation. And this is what was bandied about around the world. We said, if you're not on a ventilator, but you're on some supportive device, why not stand or sit in a chair? Because that expands the lungs probably better. Innovations from resource-poor settings. We innovated surgical masks over interfaces to prevent spread. And in fact, we have sound ethical triage systems that we've implemented that others, in fact, are adopting. And we've tried to provide an ongoing service, very importantly, for non-COVID-19 patients who should not be forgotten in the context of things. We've also been flexible. It's not been dogmatic. There are no COVID-19 experts. We are all learning as we go along, and experience is maybe what we've gained along the way. And so we have followed trends. We've continuously engaged with some of the contacts we have locally and abroad, fortunately, with a host of authorities, individuals, and groups. And as a consequence, we've gone back, introspected, and modulated, manipulated, and reviewed what we are doing. As a consequence of that, and I won't go into the medical issues, we have a far better idea now of whom to intervene with, when to intervene, how best to intervene in a simple fashion that results in better outcomes. And in fact, some of our outcomes now are extremely favorable. What all of this has done for everyone in the profession, on the ground, is bring back the issue. Take away the panic, take away the fear, take away the anxiety. We are so proud and privileged to be in this profession. It's something that, in fact, every single day we're reminded of. Despite the elements that people go out there and put their lives at risk every day, it's truly a privilege to be in the profession, and it's our very patients who bring that to the fore, both COVID-19 and non-COVID-19 patients. I want to spend just a moment on critical care, because critical care or intensive care has been one of the services that has had to absorb a very significant number of severely ill patients. And perhaps it's been an entity that has been a little bit neglected, but very many have benefited from just a few who have given so much. And I want to pay tribute to every single healthcare worker across the spectrum, and those as well in critical care, who've really done an absolutely fantastic job. In fact, critical care is now being regarded and is described as a scarce human resource. And once again, just kudos to all the courageous champions. Human elements are really important. And the field that I work in is called critical care. And I like to turn it around. And something that we should never forget on the ground is that it actually is critical to care. And when we practice that across any spectrum, we should never forget this wonderful spirit on this continent that we are privileged to live on, in this province that we're privileged to live in, and in this country that we're privileged to live in. And that is the spirit of Ubuntu, which is a definitive phenomenon, South Africanism, an African entity, which tells us we must go about our jobs with compassion and to be humane. And if we do that, and that's what we've been trying to do, we're really going to go a long way. We also need to treat our colleagues within a similar spirit, and anyone that we have interactions with. And so let me share some human elements with you. This is a patient who is deemed not to be suitable for ventilation, invasive mechanical ventilation. And we should never forget that we're dealing with human beings. And this particular individual requested that prior to them leaving this earth, because that was imminent, they would like to see a sunset for the last time. And so this patient was wheeled out to see a sunset as the sunset on his life. And those are the elements that make a difference to us every single day. So it is possible to make a difference, even in the face of adversity. And I hope I've shared some issues with you. Nothing is impossible. In fact, I like to turn the terminology around. Impossible is nothing, provided you have the will to want to do that. So I think it's pertinent to finish off with someone who all of us resonate with, and this individual resonates with me very, very deeply, who taught us that we can overcome challenges and burdens and obstacles and hurdles. And Nelson Mandela had the following to say: "It's in your hands to make a difference." I don't know if anyone in this audience would like to finish that quotation off, because I think it underpins everything that we've been speaking about today, the science, the elements, the human issues, the clinical interventions. It goes as follows: It is in your hands to make a difference, to make this world a better place for all who live in it. And that's ultimately what we are doing and trying to do in the face of major adversity. And if we can go about with that sort of knowledge and that adage, we're going to get through this, as we have. We've got through the first surge, we are getting through the second. Everyone is trying their best. And it's all underpinned by what Nelson Mandela taught us. So the Premier, when he started off this morning, in fact, brought to the fore something that many of us have not had opportunities to do in the last many months, and that's take out a little bit of time and resonate with things that actually everyone can associate with, and that is music. We lost 2 musical icons the last few days. And in the school next to the hospital where I work, I would pass this school every morning, in a very early morning, and sometimes very late at night, and sometimes very early in the early hours of the morning, as we were dealing with patients with COVID-19 and doing our very best to try and confer a service that was commensurate with the dignity and the decorum and what every single patient deserves. And this school put together with the choir, with something that makes us feel proud to be residents of this continent and of this province and of this country. And I want you to just take in some elements of this. It really is a wonderful way to finish off issues. I hope the sound does play. And it's a song written some years ago. It's been covered. I'm not sure the sound. Could we get sound, please?
Well, I heard
It's about rejoicing in the joy of life.
That David played and it pleased the Lord, but you don't really care for music, do ya? Well, it goes like this: the 4th, the 5th, the minor fall and the major lift, the baffled king composing hallelujah.
Just because
Your faith was strong, but you needed proof. You saw her bathing on the roof, her beauty and the moonlight overthrew ya. She tied you to her kitchen chair. She broke your throne and she cut your hair. And from your lips she drew them, hallelujah, hallelujah, hallelujah.
that is why we have to go out and do our very best. That is a group of young people that reflects what our country is all about. The song reflects where we ought to be going. And it's a good reminder that we all need to rejoice actually in the joy of life and pay our homage and respects to those who in fact did pay the ultimate price here. But there is hope, and whenever there's hope, there's light. And if there's light, we can all move forward. And on that note, I'm going to leave you, and thank you so much for this opportunity.
Thank you very much, Prof. Can you hear me? Okay. Prof, thank you very much for that moving feedback. We have had our scientists here, data scientists, the public health specialists like Mary, who have been coming to give the numbers. But you brought something else, being in the cold face of these numbers about the human side of it, what this means for the healthcare workers. And you brought, I can tell you, you brought into this a very, very moving and emotional for us who are listening to you about how our healthcare workers dealt with the situation we were facing. That there may be places where things went wrong, like at Tembisa Hospital, but that there are many other places where many things went beyond what was even planned. We didn't know what the clinical feedback will entail. We just knew that the clinician who sits in the advisory panel wants to share the story of what they went through during COVID. So thank you for your story, Prof. It's a tremendously impactful story on even us who are just listening to you. I'm going to ask that we move to the next briefing on the vaccine rollout. The HOD, acting HOD of Health, is going to take us through that. He's going to be very brief because when we get to the government side, the science of it has been told and the clinical implication of it has been shared with you. We must get these things done and resource them. And this can't be a long story. Only professors are allowed to tell a long story. One day you might be a professor. HOD, only when you become a professor you can talk for long. Please come through.
Yes, MECs and the colleagues that are with us. Premier, I promise that I'm not a professor. I'll be brief because really the science and the numbers have been dealt with. Mine is just to quickly just outline where we are in the province as far as this matter is related. So we have a master plan that is being approved by the PCC to roll out a vaccine. As you know, that the actual coordination of the vaccine rollout is centralized at national. We as a province, all we need to do was to get a house and a ducks in row for the purpose of implementation as soon as the vaccine arrives. As the minister has articulated that the vaccine will arrive on Monday, it will go through a process and it will reach provinces within a week or so, up to a maximum of 14 days beyond that in the province. So what have we done as a province? And this I'm just deliberately showing because we have all the what's being as a planning All the activities for planning purpose have been done. In terms of identifying the sites, we've got over 700 sites that are currently registered with National Department of Health as vaccination sites for phase 1 and for phase 2 and 3, which I'll deal with in the next slide. We already have 2,000 identified sites, and we're going to use as many sites as possible when we do the other phases, as we want to vaccinate as closest to a community, as closest to the population as possible. So the issues about identification of sites and listing them and ensuring that those sites meet the minimum standards, and I'll talk to the minimum standards when we get to the next slide, have been done, and all we are waiting for. If vaccine were to arrive on Tuesday afternoon and we got 20, we'll be able to administer 20. If we got 300, we'll be able to administer 300. That's the level of readiness we are as a province as far as that matters is related. This is just to recap. The minister has spent quite a lot of time in the past couple of weeks educating the nation in terms of how the vaccine rollout will be. As we know now, just to confirm, it will be in 3 phases. What will start as soon as early next week, it will be the phase 1, the frontline workers, and across all. And when I say all, that means across all levels. Municipal workers that are in health, in frontline health workers, those that are in private, those that are in mining, everywhere else where you find frontline patient-facing or patient-interfacing health workers, those are the first cohort. Of course, immediately once that population is covered, we cannot get herd immunity by just doing health workers. So the next 2 phases will then be phase 2, which will be the biggest exercise, of course. That will be essential workers. I think they are known, the policemen, the soldiers, prison warders, and teachers, and everybody else will make fat part of that. And of course, people living in congregated areas, people over ages of 60, and people who are over age of 18, with, of course, underlying conditions. And then the phase 3 at the population level will be. These 2 phases, the phase 2 and 3, are the biggest health exercise to date, given the speed at which the vaccine needs to be rolled out, and of course, whatever doses we have, we must remember that the vaccines that we currently will be rolling out is a 2 dosage. So whatever we'll get, we must just think about giving it two dosages. So in terms of the vaccine sites, I've reiterated and I've double-checked with National this morning that Gauteng has registered over 600 sites for the phase 1 process. So it means all health facilities, whether it's a municipality, at the province, at a CAC, a clinic, will be used as a vaccination site for the purpose of phase 1, and those will then be included for phase 2 and other. The PCC, the Provincial Command Council last week looked at the plan and said the plan is sound, but the plan ignores that Gauteng has an infrastructure that's already out there. There's municipal infrastructure, there's mines, there's big industries. Go ensure that in your plan you factor in all those big industries so that you maximize the existing infrastructure for the purpose of course reaching herd immunity as quickly as possible. So that's really the context and the gist of what we'll be doing. We're just really showing what capacity exists in the province in terms of where else, and this is better elaborated in the next slides, which will be the second last slides, that we've got, of course, clinics, retailers, and independent community pharmacies that are at the end. That is where we want to actually target, that besides the health and government institution and municipal offices and recreational halls, that those pharmacies that are already in the community base, that all communities are accessing them on a day-to-day basis, be also added as the majority of the vaccination sites for the population control, for the population access. And that's really the gist. And what we are in fact saying is that as many sites as possible will be used to access and of course to achieve the herd immunity as quickly as possible. This is probably the second last slide that I'm going to show. This is just really, the slide is just indicating a process flow, that vaccinations and vaccines will, of course, as the first phase will then be dealing with for the purpose of all health workers, but at the same time, that rollout includes all private, so the vaccines will then, as they arrive in the country, once all the verification is done, quantities will be issued to private, quantities will be issued for for government for the purpose of rollout, and then of course there will be a distribution across the sectors. So public health sector, vaccination site, community health centers, provincial hospitals, and of course those that will be given to private sector will then be follow a similar pattern. Every vial of vaccine must be accounted for, and hence there is a registration requirement, and also of course there are issues at the back end of managing, ensuring that no one double dips. I don't know why one will want to double dip for what reasons, but also to ensure that we quickly get herd immunity, because I mean you've got health workers that are dually employed, that they work both in government and in private, so we then need to be able that they get it once. So those are the back end system. So in terms of what is the supply and distribution, of course, once the vaccine lands in the province, this is the last slides I'm going to reflect, just to ensure that I keep to my promise. So we are going to use private hospitals, in provincial hospital, provincial clinics, private pharmacies and clinics, any general practitioners that of course wants to participate, occupational health sites, vaccination sites. These are the ones I've referred that as far as things stand, we've already registered over 700 to date. The wholesalers, of course, you've got private pharmacy groups, general practitioners, and all what is required really is that you meet the prescribed minimum standards that are articulated and prescribed by national. Of course, it's about the minimum requirements so that all vials are accounted for, that they've got sufficient storage. Of course, the main issue about this vaccine is about cold chain, that you've got the capacity to store it at an appropriate temperature, that you're able to reconcile what you receive vis-a-vis what you gave, and it can be accounted for and linked to a population register that national will be administering, so that all can be accounted. So that really the distribution there, it's about who is already on board, and really the principle and what national is trying to tell us provinces, that let's get as many people on board as possible to ensure that the herd immunity that we are aiming for, as as Dr. Kaunga articulated, that we get to there as quickly as possible. Premier, I hope I did not do the proper time. Thanks so much. All right, the Premier just reminded me that the critical and matter of interest might be how many people are aimed to be vaccinated. As we had said at the outset of the presentation, is 67,000, 67% of the population, and that brings us to about just under 10 million in Gauteng. At across all levels. So that means the phase 1, 2, and 3, when we said we've reached the herd immunity in the population, that's the number we're aiming for. And of course, the sooner we can get there, the better, with the phases that are being prescribed currently. It's about 10.2. Yeah. Thanks, Premier.
So 10.2 million people in Gauteng province. When we have reached that number, we would say that it protects everybody. I would like at this stage, again very, very briefly, just to connect with what Professor Mervyn Mayer was saying about the importance of critical care for the MEC, for infrastructure to come and just do an update about the number of additional critical care beds outside what was added in each facility, that we said by the end of this month we will deliver additional how many critical care beds as part of the response, and this was the response to the second wave, but it is a part of building for the future. That critical care capacity, and this is the message we've been getting from the clinicians, critical care capacity is important to say. This is one of the things COVID-19 helped us to resolve. We seized that opportunity. MEC Mutara, she will be very brief. It's not everything.
Just to indicate that at Anglo Gold, as we had communicated earlier, The Anglo Gold facility is complete. What we are doing now is commissioning the oxygen and testing oxygen to the beds. That will be completed by next week, Friday. And on Saturday, thereafter, the Department of Health can begin moving in. So from Saturday next week, the Department of Health will be able to accept admissions at Anglo Gold, and that is an amount of 175 beds. It's critical care in total, all 175. And I think it's important to say that the Department of Health has been ready to use the facility for quite some time in terms of staffing as well as equipment. But there were just a number of challenges on the site from time to time. But we are now at the stage where we're ready to hand over by Friday. At Bara, the ABT, or the Alternative Building Technology facility, Premier, we've completed 400 beds there. 50 will be completed by Monday. And as earlier communicated, the last 50 will be completed by the end of February at Bara. We earlier would have handed over 300 beds, which are commissioned, equipped, furnished at Bara, and Bara is ready to use that as and when, and they have been ready to use that for quite some time. So the last 50 out of the 500 beds that we have done at Bara will be completed at the end of February. At the Dr. George Mukari Hospital, which is also an alternative building technology facility, and there we did two projects. One was what we spoke about, was the in-facility, where we repurposed wards in the facility, and that was completed quite a while ago. Now we are finishing out of the 300 ABT, 150 will also be finished by the end of this week, handed over to the Department of Health for them to be able to use it from Saturday. And the last 150 out of the 300 beds will be ready by the end of February. We were a bit worried about the roof, but we know that we are just busy with finishing on the inside. The roof on the walkways will be done when the rain dissipates. But otherwise, the facility will be ready to use. Thank you, Premier. At Jubilee, we handed over the ABT facility at Jubilee Hospital, complete 100%, 300-bed facility. We handed that over to the Department of Health in November last year. And we were pushing to make sure that prior to the festive season, Jubilee Hospital would be able to have that facility to augment not only just for COVID, but also given what happens over the festive season in that area particularly. We do know that they have been using the facility since we've handed over. So all in all, since November to the end of the current week, we would have handed over 475 between Jubilee and Anglo, and 450 just at Bara. That then gives us, my maths is quite bad, so I'm not a professor, but 475 plus 450 is somewhere there. Thank you very much.
Ask the MEC for Health just to deal with additional response to the second wave, especially on the human resource side, additional staffing. As we have additional beds, you cannot have additional beds. Beds don't run themselves. It's people who manage our healthcare services. So the MEC is going to indicate how many new staff we have been bringing on board. Some of them is for the response now, but we're reprioritizing our health budget so that these are permanent to help bring additional capacity. Our doctors, our nurses are working under tremendous pressure. So the need for more staffing is something we are dealing with every day. MEC for Health, Dr. Mkheti.
I think I'm taller than the Premier. Thank you very much, Honorable Premier, MEC Mutara, HOD, members of the advisory committee, members of the media, people of Gauteng, good morning. Maybe first, Premier, just to appreciate what Prof. Mayor have shared with us, I could not agree with you more on that one. You have shared what you are experiencing, what our people out there are not aware what you are going through as clinicians on daily basis. And that was very emotional. And it also, I think, gave each and every one who is in this room an opportunity to reflect and to do introspection, and also to appreciate what our frontline health workers are doing for our communities. In the midst of everything, they contract the disease, they get isolated, they quarantine, and in the midst, some of them are admitted and lose their life. And just to share with our people today, to say to date, since the pandemic, we have 60 frontline health workers that have succumbed to the virus. And we have also lost some of the critical people in the health sector, your clinicians and some of the specialists. And I think as a department, Premier, under your leadership, we're saying to those families, we really thank you for borrowing us, your members of your families, to take the risk to work under these conditions. And some of them, Premier, I have been interacting with them. They have been saying it is really painful to lose people on a daily basis. It is really painful to lose their loved ones, their friends, their colleagues, and this is really putting pressure on them. And Premier, we had been giving psychological support, and we have strengthened that, and now we have also included the faith-based to assist us to make sure that they are also assisting us in making sure that their psychological being is also being taken care of. I really want to thank all those health workers today to say keep on fighting. We will win one day this pandemic. We know that you are fatigued. It has been some time since we had been fighting the pandemic, that we are saying hang on there. One day we will be able to say we have won this pandemic. Premier, maybe just to focus on the additional staff that you received from National Department of Health to assist with the pandemic, we have received to date 42,373 staff members. And colleagues might remember in the previous briefing, myself and the Premier did give feedback on the 983 post-ComServes that we are supposed to absorb in the system. We have done that. Thank you very much, Premier, for supporting us in making sure that we absorb them. We have requested all the facilities to say where there are vacant budgeted positions, absorb them with immediate effect, and then those that cannot be absorbed, we are going to give them a 3-month contract because at this point in time, we are sitting at 267 million to be able to cater for all of them. With a new financial year that is going to be starting in April, we will be needing 1.2 billion only to cater for those ComServes that will be absorbing in the system. And for us, post-ComServes, post-community service nurses and doctors. Thank you very much, Premier. And then we also going to admit now, remember I spoke about the post-ComServe, now I'm going to talk about the community services. We're going to admit 830, but we're not going to admit the 830 at once. We're going to admit, I think we've already admitted 79 for January. For March, we're going to admit 199, and then 299 in April, and then 250 in June. This is simply because they will be completing their course on those months. And then on the peak Honorable Premier, we have a capacity of 2,535 nurses, and then we have 445 doctors, and then others, your porters, your cleaners, and security, we have 306, which give us a total of 3,296 at a cost of 1.1 billion, Premier, and this will only cater for up to the end of the financial year, and we're going forward. We will be planning for the new financial year. And thank you very much, Premier. I think I have covered everything, and I would like to thank our people for being patient with us. Thank you.
Thank you very much to the MECs, just to demonstrate that there's work that has been happening to really build this additional capacity, and a critical part of this capacity is to ensure we go beyond this period of COVID. I just want to say that by the beginning of February, as we start the new month, we will have an additional 925 critical care beds added. We had said by the end of this month, which is January, we will add additional critical care beds, so 925 of them. Those are the two numbers that the MEC was talking about. Before I conclude, I want to share with you how many people we have in hospital. Dr. Mary Kaunga showed the weekly numbers. So how many people do we have admitted in Gauteng hospitals in both the private and the public sector? As of now, these are the latest numbers. It's a very, very important indicator also of where the pandemic is. So, and we have to countenance all the other numbers that are going down. It's still very important to say we still have 5,338 people admitted in our hospitals as we speak. This is the current number. At the peak of the first wave, we had reached 7,000 in combined. We breached the 7,000 mark in both public and private sector. So we have 5,338 as we show you there, and their distribution is important. 1,457 are in ICU and high care. So you'll see those who are on oxygen and on room air, others are on ventilation directly. But sometimes just having oxygen points saves lots of life. That's the feedback from the clinicians. And you can see the split. We have fewer in the public sector. Our capacity is still there. And I'm going to tell you the story of Nasrec to understand. When those who politicize COVID run all over and say the province is not ready, it is not based on an accurate assessment. A week, 2 weeks ago, they had headlines that were running around, people trying to be relevant. The province is not ready for the second wave. You got today the feedback. Being ready is not about being dramatic about it. It's not being political about it. It's to assess what is the situation, how are our healthcare workers coping, what additional healthcare workers should we bring in, what additional beds should we bring in. So the pressure is still there. Just go back to Dr. Mary Kaunga's story. The pressure, yes, the the trajectory, the pandemic in our province is plateauing, but the pressure on the healthcare system is still there. 5,300 patients is a lot of people at each given day. And let me also share with you something. When you have a lot of patients admitted in hospital, the risk that we may have the fatality numbers, in other words, death numbers may increase. Even if the infection rate is going down. But when you have more people admitted in hospital, it means that the number of people who pass on, the risk is very high. So if you may see that from some days, the number of people passing on in our province, it's over 100, and there's a day that it just got to 202 in the past 2 weeks. You must remember how many people are admitted in hospital. With all the interventions that are made there by our healthcare workers and all the therapeutics and all the other interventions, when you have more people in hospital, the chance that you will lose a lot of them, the chance is pretty high. So what message am I sending? We still have a lot of capacity, but we are concerned that there are still too many people in our hospitals. So no one should be going out there and say, we have passed the second wave. Let them just open up everything. Let's take the economy back. Let's take the country back to level 1. All the other arguments people make, which are both economic and sometimes just purely political, they have to be balanced. Economic arguments are very important because, our people more people need to go to work. We need businesses to reopen. But to simply think alcohol must be brought back. I'm showing you the numbers. As we speak now, we still have too many people in hospitals. The good thing, though, is that we have available beds that are not filled up by people who would have been trauma patients as a result of abuse of alcohol. So this message is important to get out there. We are not celebrating as yet. The other numbers are going down, but the hospital admissions are still too high, and it is a matter of great concern to us. Even as we add additional beds, we don't want to reach to a point where the system will not be able to cope. The other thing is that you remember 2 weeks ago, we said to you that we are upscaling at Nasrec. Nasrec currently has got 1,000 beds. 500 of those are able to offer critical care, at least on the side of 300, over 300 of them have oxygen points. But currently the uptake at Nasrec is still very low. We had taken a decision that we will upscale back to 1,500 bed, but we still have more than 400 beds at Nasrec that are not being taken up. So the pandemic is very dynamic. Prof Mayor was saying there's no expert on this. The pandemic is very dynamic. We can't add another 500 beds when the numbers say we may not need those, especially as we bring in this. So Nasrec is still 1,000 beds at the moment. We are just holding up. But we can always, at the shortest space of time, go back to Nasrec and say those 500 beds must be brought on stream. So we have to do these things, monitoring the trends, monitoring the numbers, and not being put under political pressure, which is typical, very typical of the political sphere. People put you under pressure, not based on the science, not based on the numbers. And maybe it should be understood, especially that political opposition parties are about putting government under pressure. But we must respond based on the science, not on the pressure that they are putting. So I want to say that that's what we are going to. There may be statements made out there that it is time that level 3 must be, we must lift level 3. Our attitude will be the following. We are monitoring every other indicator of where the pandemic is, and we are very concerned that the number of people who are still admitted in the hospitals, the number is too huge. We are also going to say the hotspots are still there. Although the hotspots have slowed down, they are less severe, but we will say there are still too many, over 300 hotspots in the various communities in Gauteng. They can easily spark another wave. So if we are asked what is your attitude to just removing all the restrictions, we will say we have to be very, very, very careful. The hotspots are still there. It is easy for an outbreak. There may be other restrictions that we may talk about. I want to say to the people of our province, you responded very well after people returned. When particularly many who traveled back into the province, you responded very well. I can say that in Gauteng, more people are observing the mask, especially wearing the mask, than at any other time during the pandemic. And I see a lot of compliance, and I don't want to believe that it is just about because they are afraid to be arrested. But I think the awareness is a lot more. The third thing I would like to say on the pandemic on the vaccine rollout, there are still too many people who are hearing stories about the vaccine and who believe fake news and conspiracies about the vaccine. We can tell you we want to vaccinate 10.2 million people. We can tell you how many sites there will be there. But if the people do not arrive, if everybody has got a new fear, from fear of the virus to fear of the vaccine, we will be in big trouble. We will not reach population or community immunity. So my message is, let's get out the right message to our communities about the vaccine. Vaccines save life. All the too many things people say, the anti-vaxxers, anti-vaccine campaigners say about vaccines save life. The vaccines must be safe, and that's why there are trials on all, and that's why there will also be monitoring. The vaccination program will be also about monitoring those who are being vaccinated. How are they responding to it? So I want to assure the people of Gauteng that when the time comes, starting first with the health workers, all the health workers must go and get vaccinated when the program starts. When we go to the other essential workers, including our policemen and women, who in the course of this, especially in January, a lot of them got infected as well. When the time comes, don't hear stories about the vaccine. Please come to the fore. Vaccines save life. And this message must reach out to all people in our communities. Don't choose some therapies over the vaccine. There may be therapies that will help, and many of us, I contracted the virus. I was sick with COVID-19. I know many other things, both prescriptions by the doctors, as well as home remedies. I know many other things that people don't choose. Don't say you will not use, you will just use home remedies. When you have a problem with your chest pain or you can't breathe, you need to be seen by a doctor. You need to be admitted in hospital. Some of the places, there's anecdotal evidence that we have gotten from family members that people thought when the chest pain comes and when running short of breath, thought that what will help you is just steaming. Steaming may help you with other things. When you reach a point that is critical, please go to the hospital for them to attend to you. It is very, very important. And vaccines will help you. Other remedies may be very helpful. We grew up with grandmothers who gave us things to drink when we're not feeling well. But take those things together with modern medicine. Don't say you will not choose vaccines. You are going to just resort to indigenous systems. These are times where we must combine every effort to save lives. Having said that, I want to say that as we fight COVID-19 and as there's hope on the horizon, but corruption will continue to be another virus that will not just recede without being combated. We've got to use all combination of means to combat this virus called corruption that threatens all the successes, all the achievements that are spelled out here by the team of scientists that show that as a province, we have done substantially well in responding to the pandemic. In the first phase, yes, we have lost. Our number is getting close to 8,000 people who have passed on. The recovery rate is always improving. Our healthcare workers have saved many lives, but we must combat corruption. And it is on that note that I want to say the following. There's been lots of stories started by a newspaper, the Sunday World, published an article last Sunday. And in that, that article was headlined, Makura Fingered in PPE Looting. That is the headline. And they published the story based on a case that the SIU, the Special Investigation Unit that has been working with us to ensure we do get to the bottom. Everybody who was involved in the PPE corruption must be brought to book. And the money that was lost must be recovered. The Special Investigation Unit correctly went to a special tribunal, which is a special court. And when they went there, it was part of the money that they are recovering to prove to the court that there are service providers that got involved in unlawful, completely unlawful procurement processes. The Special Investigation Unit went to the court, and when they went to the special tribunal, the court awarded them. The application was that where they have stopped the bank accounts, the money must be returned to the state. They won the case, and we welcome that. It's a very good example that in the state we need to stop a situation where when there's unlawful procurement, both the business people and any official of state who was involved in unlawful and corrupt and irregular deals must be held to account. So they won the case at the special tribunal. So in one of the affidavits filed there by a defendant, the former CFO at the special tribunal, the former CFO cites in the tribunal that amongst other places where she got names is the office of the Premier. I want to emphasize, anyone who has read that tribunal, who has read the affidavit, it says she got some of the names from the office of the MEC, some of the names from the office of the Premier, some of the names from the HOD. That's what she says in the affidavit. In court, she was arguing there's nothing wrong. Wherever she got the name, she was arguing her case. I'm not dealing with her case. Based on that affidavit, remember what the affidavit says. She got some of the names from the office of the Premier. As the Premier, I took very, very seriously the allegation that she got some of the names from the office of the Premier. But the presiding judge, Judge Mutle, in summarizing the judgment, made reference to the fact that in paragraph 14 and paragraph 24, made reference to the fact that she got the names from the Premier, the MEC, and the HOD. Not from the office, but made reference to that. I have since taken the following steps. I have written to the judge to say in the judgment that was correct, that we are happy about the judgment that money must be recovered. There's an area where she makes reference, where he makes reference, the judge, to what is in the affidavit, which is not in the affidavit. So we have tabled that application. I've tabled that application because substituting the office of the Premier to the Premier is no small error. I would like to say to you that the judge of the tribunal has acknowledged, the judge of the tribunal yesterday wrote to me to acknowledge that he has received the application and it has merit. But he will make his final decision and announce it about the application. And the application is a rectification relief. So I'm not challenging the judgment about the recovery of the money that must go to the state. I'm challenging a section where it makes reference to what is not in the affidavit by anyone who came into that court. So there's no one in that court who had said the Premier has submitted names. So I am very glad that this matter is serving before the special tribunal, and I am awaiting a ruling by Judge Mutle, and he said he will do so before early next week. I don't want to say the specific date to you. I want to leave that to the judge. I am very happy. He has acknowledged that the application I have filed about correcting, and then the application has merit. Why am I explaining this? Because a newspaper, and now it got into the political terrain. I was talking about political parties, opportunistic by nature. So anything that they grab, they don't have to read a document. They don't have to read any document. So the second thing that I have done is, even just making reference to the office of the Premier is very serious an allegation. So I've now referred to the SIU through the DG of the province, that affidavit of the former CFO. So I'm saying, an inaccurate reflection of what the affidavit says is something I'm dealing with the judge. But even if it was reflected correctly, I would have still taken a view that any reference to the office of the Premier here as it pertains to the unlawful, irregular procurement that took place on PPE in the Department of Health, I would still have taken a view that that affidavit must be investigated by the Special Investigation Unit. You remember the Special Investigation Unit is dealing with, as the result of the proclamation, all PPE and COVID-19 investigations are done by them. I want them to do that. My name has been brought into disrepute. I want that to be attended to. My name has been brought into disrepute. Part of it, there may have been a genuine misunderstanding, either by a newspaper or the political party, or even the organization that, any political organization that says the Premier is corrupt, he must be investigated. They are citing an affidavit they have not read. And I think it is absolutely sad. I have looked at the statements that have been made by the DA. They are making to a reference, they have not read the affidavit. They have not understood what the problem is with regard to the judgment that has been made. But I want to assure the people of our province, I am not fighting corruption, not because to say so is good. Corruption must be fought. Clean governance is something we must ensure takes place in this province, as long as I am the premier, and I'm convinced as long as the ANC has been given the opportunity by the people of our province, we must fight corruption wherever it finds itself. Now, these two things, so there's the judgment, and then there is the affidavit's reference to the office of the premier. Anyhow, both of them bring into question my integrity. The two of them bring into question my integrity. How do you deal with that? As I say, I've already done two things. The one is that the Special Investigation Unit must investigate and get the truth, because affidavits must themselves be subjected to a process of law. And I'm very clear that I want to reiterate, I have not given any names of any PPE company to any official, either in the Premier's office or in the Department of Health, for them to be appointed to provide PPE in Gauteng. I want to repeat that. And this affects, I have done a sworn statement in my application to the judge. I know that any other issue about, and I know there are many other issues that are being said there, and I will deal with the politics. I want to focus on the fight against COVID-19 now. I want to focus on that. I don't want to be distracted. In addition to those legal steps I've taken, I've also briefed the ANC leadership about the fact that I want to go to the Integrity Committee. I briefed the ANC provincial leadership on this matter. I want to go to the Integrity Committee. As these processes are unfolding, I want to go to the Integrity Committee. I am clear in my mind. I have a clean conscience. There is no incident, one or two, in any of the departments of the Gauteng provincial government. Since 2014, in the last 7 years as the Premier of Gauteng, I've not sought for one occasion to enrich a friend of mine or even a comrade of mine, to enrich them. I've always insisted procedures must be followed, things must go, and I've also always said to my colleagues in cabinet, it is important, colleagues in cabinet, that none of us is involved in corruption. I've done that. In May, I wrote a letter just in the midst of COVID, a letter to all our accounting officers. We are fighting COVID. We don't want to be sidetracked by any acts of corruption. I wrote that letter to all our accounting officers. The truth, though, is this. There has been incidents, the outbreak of incidents of corruption that breaks my heart. It breaks my heart. In the light of the pandemic we are facing, that is the truth. And that's why we had said at the very beginning, everywhere where corruption took place, the Special Investigation Unit is already there dealing with these matters. And therefore, as it pertains to myself, I would like to say that I was advised that I should allow the ANC to have its own processes. I had thought and reflected a lot. When you know the truth, and the truth is that anyone who thinks we now got him, it was very interesting to read that article. It starts by saying, for the first time. anyone who thinks we now got him, he is involved in this one, we got him. If the aim is to get me, I think you have to work for a different cause. I think there have been attempts, smear campaigns. The journalists who were writing the story were saying, but do you know that there are people who are meeting? I don't want to focus on people who are meeting. I want to focus on the facts. To the judge, to the investigation authorities. I want to focus on the facts. And therefore, there is really, really nothing. I will continue in this province. I will continue to be in the front line as a leader of government. This is an ANC government appointed by the ANC. If the ANC comes to me one day and says, Premier, thank you very much for the work you have done. We think that it is time for someone else to do this work. My attitude is always say that we are deployed at the service of the ANC. But I will not, on the occasion of an orchestrated campaign to discredit me, an orchestrated campaign to cast aspersions and cast doubt on my integrity, the only thing I'll fight for is my personal integrity. I have nothing else than my personal integrity to defend. And I'll continue with all the efforts we are making, working with my colleagues in cabinet, in the Gauteng provincial government. Wherever there are allegations of corruption, we will go there. The first thing to do is to have an investigation. When there are allegations, there must be an investigation. When the investigation comes, and the investigation has findings, and this is the course of action, we act on that course of action. I had to act on very difficult issues that investigations have said to me, please take action. I'll continue to do so. So that includes any other department in our province. I have noted and have had a discussion with the MEC for Education. MEC Lessufu briefed me in detail about education as it pertains to the deep cleansing, the decontamination of schools. That matter is now a subject of investigation. The SIU has been investigating all the COVID matters, but it is important that we, MEC Lessufu had referred the matter again to them, but you should know, I have said it again and again. Any allegations of we didn't get value for money, there were corrupt practices, there were things that happened there, that must be investigated. And the ANC has its own processes, and the ANC processes will run their course as well. But I want to say, without fear of any contradiction, I stand before the people of this province. As someone who holds political office, I expect that there will be mud thrown at me. I expect it. But please know, I will not throw myself in the mud. I won't wrestle in the mud. If mud is thrown at me and others are in the mud, they're inviting me, like political players who want me to wrestle with them in the mud. As long as I hold this office, I will respect that I mustn't wrestle in the mud. I want to conduct, even dealing with these accusations, conduct myself with a great deal of restraint. I'm not going to be responding to accusations and calls being made. I have been able to present a report. I'm taking the people of Gauteng into confidence what that report says. What the affidavit says, that affidavit is available, is public document. It may be ignored because it doesn't have the juice people want, but it must be investigated, and it is being investigated. Secondly, others are using the judgment to say, no, but the judge says. I take that judgments are historical records and they are precedent-setting decisions, and that's why I have approached the court. But the ANC itself has taken conference resolutions that when you are a member of the ANC and you are accused of doing certain things, there are certain processes you must undertake. And that process of the ANC will also run its course. And I'm saying all these things with a clean conscience that we are doing everything in Gauteng to push back corruption. It is not easy. Sometimes those who are beneficiaries of corruption will do everything. The beneficiaries of corruption will do everything to try and throw mud at you. If you are standing at the gate and they want to enter and catch the loot, if you are standing at the gate, what gangsters do when they find a security guard at the gate and they want something in there, they have to demolish the security guard at the gate. I am clear and in my conscience that I will never defraud the people of our province. When I am asked to leave the position of Premier of Gauteng, I'll do so knowing I served in the 7 years, which is 7 years now. I do so knowing that I served the people of Gauteng without even the temptation to loot from them or enrich any of my friends or family. There have been previous attempts to throw this story there about Makura is involved in this. When they follow up, they find out that it is yet another thing to chase. So I want to say to you, guys in the media, those who thought, now we got him, I am very, very clear that the ANC doesn't send me to government to come and loot. And anyone who gets sent into government to go and loot must be found, and they must be removed, they must be put in jail. The processes of doing so are very, very clear. So thank you so much. I think we are ready. We have presented everything today. We are ready to, I am ready to take questions from you and my colleagues in cabinet who are here from health. Thabo, please come back. I want to thank the professors, and I'm releasing you. I thank you, and I'm releasing you. I don't want you to get into the mud. Don't get into the mud. That's the place of politics, where people throw mud at you. Go and do your work, and we thank you sincerely for that. Continue to make us proud.
Okay, thank you, Premier. We are now ready to take questions. We will start here. I see hands here. Can we have the mic moving there? And please just introduce yourself before you ask your question.
My name is Malungelo Boy from Newsroom Africa. Premier, are you then saying on the issue of these restrictions, there has been this conversation about opening up, alcohol sales because of how that sector is suffering? Are you then saying, even though we're seeing a decline in COVID-19 cases here in Gauteng, you're saying that it's too early to have that discussion or to lift, the alcohol ban? Also, on the issue of people trying to discredit you and this orchestrated campaign, who would want to do that to you, and why? With this issue of deep cleansing of schools, that over 400 million rand, right? Do you think you got value for money there? Thank you.
Okay, thank you very much. Let's take the next one.
Thank you so much. It's Govind from ENCA. Premier, we've heard your clarification that you say that at no point did you give anyone names to have that company receive a PPE tender. I just wanted to say, to find out how far along is the investigation into the allegation that someone from the Premier's office gave names to the former CFO for those companies to receive tenders. And then, Premier, to which extent do you believe that the number of PPE corruption allegations and investigations and internal politics of the ANC is now affecting or derailing your response to COVID-19 in the province? And in terms of the deep cleaning of schools, could you clarify who exactly is investigating that issue with the 400 million, and when do you expect a response on what happened there? And then finally, on the vaccine, sir, they've said that most of or all of the public health sites will be used to administer the vaccine. Just for clarity, could you tell the people of Gauteng whether companies will be hired to assist in the rollout of the vaccine in the province, or will this be a vaccine that is administered only by the government without any service providers? Thank you.
Okay, those are the questions. All right, let me check if there are any. I don't see if there are people on the virtual platform. Do we know if there are any? Okay, that's fine. Then I'll go ahead and check some of the questions that we received on WhatsApp. There's one here from, let me start with the first one. I think somebody from the SABC, Nosipom Nube from the SABC TV News. Some religious organizations have been calling for the lifting of the ban on gatherings, saying they would like to be recognized as essential workers. We also understand that others have also filed court papers asking for the court to declare the regulations which prohibit faith-based gatherings inconsistent with the Constitution. What are your responses? What is your response to this? Obviously, some of these things that you are asking, Nosipo, are being dealt with by the national government. The court action, for instance, is not against the province, but of course the Premier did make a general comment, and he would be able to comment still. And then the next question is from Nozintombi Mia from the SABC TV News. And this one, it's about intern and community service doctors across the province have not been paid their salaries yet. Could you tell us why they've been inconvenienced like this? And when are they getting paid? With regard to their placement for, or with regard to the placement for ComServe, could you clarify when all the placements will be finalized and their registration, or if they are registered for the HPCSA? And then the next question is from Dennis Delport from Netwerk 24. And the question, one, please can you advise on how many people will be targeted for vaccination in each phase? And also if there's a plan in place to safeguard the vaccine in transit. Yeah, those are the questions, and I suppose Premier, the questions from health, the MEC, and the HOD would be able to deal with those. So. Okay, the MEC will answer, and then if she wants the HOD to answer some of the specific questions, you would indicate that.
There goes my mask. Thank you very much, Honorable Premier, and thank you for the question from Nozintombi Mia. With regard to the ComServes, why are they not paid? I think, remember when they are now post-ComServes, it means now they have completed their community services, so they had to be now put in the system as either doctors or professional nurses. So I think there was a delay there, but we were made to understand that they will be getting their salaries on the 4th, because we are working on the running of the system. It closes at a certain point, and then because the things were loaded in the system late, so that would also delay their payment. And it is not only them. There are officials in the office of the MEC as well. As you know that I'm new in the department, I came from social development, so they did not also get their salaries. They will be getting their salaries on the 4th of February. With regard to the registration of the Professional Council, yes, we have requested a condonement from the Professional Council that the doctors can practice without registration, and we're given up to the end of January. So we'll be following up in making sure that they are registered. With regard to the vaccine, I think the HOD will respond to that. Thank you very much, Nazmia, for that question.
Yeah, thanks, Gavin. And I said that the vaccine rollout in the province, they are dependent instead with the National Department of Health. But the value chain from the province receiving the vaccine into the medical supplies depot in the province and the distribution to all the arms in the province, as far as the Gauteng provincial government is concerned, there is no need for any service provider to do that. But we've got no control over, of course, what private health might do. As you know, that is a collaboration, a cross-sector services. I just hope it clarifies that. But as far as it's concerned in Gauteng, from the depot, once we receive them from national, until they hit anyone's arms, there is no need for it. Will be rolled out by the public service, and there's a plan in place to deal with that. I think the rest of the questions the MEC dealt with them. Thanks.
Okay, I always have to add, you know, the HOD forgets. They have already trained people. These are public health workers. Remember, we took in Gauteng 8,000 community health workers at the start of the pandemic. We took 8,000 community health workers who used to be people who were not employed in the state. They are very critical to primary health care. We took them in. They work with professional nurses and the team that has always dealt with immunization in the province. All our immunization program from child to mother to other categories that need to be immunized for different diseases. So on restrictions, Malungelo, on restrictions on alcohol, I think the critical issue for us, we hear the story about the impact on the economy. And that story, I am very sympathetic to that story, because I know a lot of people living in the township economy, a sector that is so central. The township economy is so central to our economic reconstruction and recovery plan. And over the last 11 months or so, the township economy has come under a big hammering. But there are social implications, and in this particular case, there are health implications. We've got to always balance what the economic implications are. As it is now, if you were to just remove the restrictions on alcohol, the 5,338 patients who are in our hospital, that number will, in no time, in just one weekend, we will go above the 7,000 we had at the peak of. And this thing happens very, very, very quickly. You saw it in the earlier phases. So it is not about, it's not like someone has got a passionate hatred for the sector. I use the evidence, I use the science. There are people for good reasons, for health reasons, who say alcohol is bad. But I want to emphasize that it needs to be regulated. Not banned, but it needs to be regulated. But in this phase where we are now, I can assure you that it will be a very risky thing to do, to just wake up one morning without an appropriate re-regulation of this sector. Wake up one morning and just open up. Just look at what happened in December. We had highways blocked. The Mabopane Highway R80 blocked by young people who were on a drinking spree in the middle of COVID. What did that do? The reason, Tshwane, by December 25, by the beginning of January, Tshwane was a hotspot for COVID. Amongst other things, is that type of behavior. Once people take alcohol, you can't be responsible for what else, what courage it gives them. The courage to think that, coronavirus is not around. So, but we're dealing with adults. I think the conversation must be more rational. I'm saying I'm extremely sympathetic to the impact. Those who are running establishments, that includes restaurants, people who are running establishments because they employ people, they feed families. It's a conversation. But anything that says you just lift and we just go back, I am going to be blamed by you, Malungelo boy. Gauteng is not ready. Yeah. Out of these numbers we were seeing, and let me tell you, the opposition parties, the ones calling for the restrictions to be removed, they will be next running around. The government is not ready because they never see, and probably they are doing their job. I think God help them to do their job. And even if it's swinging from one position to the other. But my job is not simple. The job of this MECs is not simple. It's not to play to the gallery. When we do the right things, we will be blamed. When we don't build, we will be blamed. When something goes wrong, yes, because we are leaders, we are accountable. People must seek accountability from us. People must say, what happened here? Was there value for money in education? You can't just tell that without a thorough investigation. Who's doing that investigation is the Special Investigation Unit. I know that, in addition, MEC Lesufi had said to me that we should ask the Auditor General's office. And as far as I'm concerned, the Auditor General's office has been working very closely with the SIU on all the issues. Where they established there's no value for money, processes were not full. At the moment, there's no allegation that there's no allegation that the MEC for Education has a deal in this 400 million and he brought his people there because there's no, the critical question is, having spent so much money, and I deeply share that question, having spent that money on just cleansing, is the money well spent? And also, did other things in the process go according to plan? The pricing would be some of those issues. The work, but you must also remember, like in health, I often say, that even when our health workers make mistakes, but the pressure to respond to COVID on these health workers is so tremendous. You heard it from Professor May. People are working under pressure. They will make mistakes, but for me, there's a difference between making a mistake and trying to cut a corrupt deal for yourself and for your family. That's not a mistake. It's a conscious effort to use the environment of COVID as an excuse. There will be areas where the public servants will make mistakes in response to the pressure. But an investigation will be able to tell you that. So who's doing the investigation at the moment is the Special Investigation Unit. And this is under the proclamation generally, because and it's not just this one. They are doing various, every COVID spend, so that we can satisfy ourselves is value for money, where the investigation finds that there are officials who did wrong things. Action must be taken. Discipline, when the AG says the officials in this department do not do things in accordance with the law, disciplinary action must be taken against those. And the SIU is following the money. The SIU follows the money. We want the money to be recovered. I want to insist and repeat that. We want the money to be recovered. Where things were done unlawfully and where there was criminal intent. So we will establish whether, in respect of education, there was value for money or anything went wrong. But someone who just says, yeah, no, Premier must remove MEC Lissufi because MEC for Health was removed. There were due processes. This is not the law of the jungle. The due processes, the first thing is that you must investigate. There are also ANC due processes, internal ANC processes. But government, the first thing is an investigation. What is the investigation saying? Recommendation. Action gets taken. If it means going to court on those who we are a law-governed society. So I am absolutely convinced that dealing with these issues in this way, one by one at a time, we will be able to roll back. Corruption is always in the lingering in the surface. And the corrupt will always look for an opportunity. If systems are tight, once you have an environment, including something like that allows for emergency procurement, the corrupt would think this is the moment. But they must not be allowed to succeed. They will not be allowed to succeed. You can only do so by following due process. And in this particular case, someone who may be accused of anything, they themselves are also entitled to challenge those in court. We are a law-governed society, so that the courts can adjudicate on the matter. And in the particular case of issues of corruption in Gauteng, I want to clarify that I removed MEC for Health not because the SIU said he was corrupt. I removed the MEC for Health because the SIU said he didn't exercise his oversight and accountability responsibility. If they say that on any of my MECs, and if they say that even on me, I will not even wait about it. I will resign. If they come to a conclusion, they say, Premier, you didn't exercise oversight. But if I'm accused of corruption, I need proof, Baba. It is about my integrity. It's not about the position I hold. I walk around, I work with civil society people, I work with the religious leaders all over this province on the basis of one thing. They know me and there is no other me. They know me as a person when I say that we must fight corruption, we must fight corruption. And that there is something that has gone wrong, someone who is corrupt, we must act on it. I don't have another David who goes out there and dishes out tenders. I don't do that. And sometimes I make lots of enemies for doing this, for standing that things must be done right. Go to the relevant authorities. I'm willing to make enemies. But when I'm not premier, I don't have a stash of cash somewhere else. When I'm no longer premier, I'll just go and work. Go and work anywhere where I can work to continue to make a living. But one thing I'm committed to as an activist of the ANC, I'll continue to work for the transformation of this country. I'll continue to do that wherever I am. And when we are in government, we are just given one opportunity to serve our people. We're just given one opportunity to serve our people. So that tomorrow, that's why when someone accuses me of corruption, I take serious exception to that. They've got to prove it. It's like the last thing that I would really want to leave. As an activist of the ANC, as someone who believes in the integrity decisions of the ANC adopted at conference, the last thing I want to go around with is that I've gotten into some corrupt deal somehow with someone that robbed the government of the money that was meant for the people. We will determine value for money. So Malungelo, you say, but who and why would someone be trying to discredit you? I have been asking these questions to people who come to me and say, we are a part of the machinery that have been asked to bring you down. I say, for what? Man, I can't be premier again. I say, for what? I'm no threat to anybody. I'm no threat to. I don't want to be the president of the republic. Such a tough job. So you are in the media. I think you must ask. You must ask amongst your friends. Bamfunani lo muntu. Bamfunani lo. But my interpretation is simple. Bamfunani lo muntu. My interpretation is simple. Sometimes if you are standing at the door, you might be standing at the door, and the way to enter the door is to demolish the guard. The HOD has clarified that there is no service providers on vaccine. We don't want another vaccine corruption. You know, I'm so relieved that there will be no service providers appointed for the vaccine program. Let me tell you, having been in government, one of the nightmares I have about government, and it's just 7 years, is when decisions have to be made on procurement and later it is found out that something didn't go wrong. Even when the officials know your standpoint, it's a nightmare. Who do you trust? You discuss with people all the time. There must be integrity. These things must not happen. But there will be another tender that comes, that this did not go right. That is a nightmare. You know, people who think that I'm staying in this position because it is nice, they don't know that the day the ANC says to me, you are done with your job, I think the thing of presiding over a leadership position where you are doing your very best on behalf of the people, but there are some chaps who sit in there thinking that they must just create as many stories and as many plots. It's one of the discouraging things about the mud of politics. So any one of you who want to join politics, guys, I'll advise you to go to church. The mud of politics is that you have to have the neck to stomach all efforts and mud being thrown at you, even if it can't stick. But you also have to be able to wrangle in the mud. I don't want to do that, please. You know, if you wrangle in the mud with the pigs will always win because you can't beat a pig in the mud. That's not my terrain. You cannot beat a fish in the river. In the river, you can't beat to enter the mud and try to wrangle in the mud. It's not my approach. All I can do is, I want my colleagues in the Gauteng provincial government who continue to act conscientiously, who are doing their best. I want them to know that that's what the governing party wants us to do. That's what the Constitution of the Republic wants us to do. Let's do the right things. When wrong things happen, let's act on them. And where wrong things have happened under our watch, let's take responsibility for that. But I've always said to people, to take responsibility is not always to decide to resign. To take responsibility is not always to decide that you must resign. And I have reflected a lot on many, many occasions on different things. That when this and this goes wrong, I'm the head of this provincial government. I've always reflected on those. Should I have stepped down? Something happens in a school. Something happens at Tembisa Hospital. Something happens in a department. The critical thing is we must know the truth. I know I am the head and that the head must be chopped. I will be very happy to be chopped, not on the accusations of corruption. If I am chopped by my organization, and it will not be the opposition, I can tell you. The opposition DA here and temptation to wrestle with the mud, wrestle in the mud is very great. Let me resist that. I didn't want to wrestle in the mud. Let me just resist it. And just allow Solim Simang to just have a bit of fame about an affidavit he has not read. He needed a bit of fame. He had gone through a tough time. The SIU is investigating the office of the Premier as it pertains to this affidavit. A formal letter has been written to them. But you say, how far is it? The formal letter was written to them on Monday, because these matters are very fresh. ANC politics, I want to say that we are just dealing with politics in general. I was telling you about the desperation of the DA just to be relevant. They have said all things we must do which have been wrong. They had said we must close down. At the critical moment, they said we must close down Nazarek. We refused to close down Nazarek. They are now saying we must reopen. We must allow alcohol to be sold. All the other things they have said just purely on the basis of a political agenda. And I can tell you that even COVID gets used for campaigning. I've looked at which political parties are hard at work. I belong to a party, the ANC. The principal preoccupation of what I have been told by the ANC is that all of us must focus on winning the battle on COVID-19 first. So it can't be the ANC that derails the struggle against COVID-19. I do not believe the ANC will. It cannot be. And I must defend the ANC. Every level of the ANC, everybody knows our critical task this year, the number one priority is to defeat COVID-19, to ensure we open up our economy, rebuild a new economy. We can't do that if we don't ensure that the pandemic is out of the way. And by ANC, I mean an organization. I don't want to talk about individual things that get said by individual things or a structure of the ANC that may say something that is excitable. I think that the ANC leadership will be able to deal with that. I am clear that what we need to do now is to protect the gains made by this province. This province has made tremendous gains. There was a period we thought the second wave will be twice the size of the first wave. And it was across, in the Eastern Cape, in the Western Cape, in KZN, the second wave numbers were twice in infection rate, in admissions, in everything else. That tendency, we thought it's coming here. The numbers tell us now that we will not get that we are helped by a lot of things. The people are responding well. The people are getting the message. They are getting the point. We are also helped by a number of things. Level 3 has worked. If there's something I want to say to you today, is that if level 3 was not introduced in December, if the country was not moved to level 3, the infection rate in Gauteng, you saw the figures 2 weeks ago, would have gone way above 100 in terms of our daily infections. Last time I briefed you, on the 12th, we had 50 new cases of COVID. 50,000, not 50. 50,000 active, not new, active cases. We could have reached to 120,000 active cases. On the 12th, we reached 6,900 daily new cases. That was the highest point in the second wave, 12th of January. If it wasn't for the measures, the messaging, and the other interventions, opening up, supporting, additional infrastructure, additional healthcare, we would be in a very difficult situation. Do you think the opposition must clap hands and say you have done well? I really don't, I don't expect that. I believe that to expect to be cheered by your opponents is to be naive. But they shouldn't mislead the people. I think they must continue to do their work, oppose us, including attacking us. They shouldn't mislead the people. Now, a very difficult question is being asked. So, the implication of staying at level 3 is that the religious establishments are not open, and they, let me say that even in the province, our MEC, who's responsible, charged with this sector, the MEC for Finance, had a meeting with the religious leaders in January. I can tell you that that is also an issue I understand very well as a person of faith. I understand that pressure, like I understand the economic impact of this. That a lot of the religious leaders of different faiths are saying, but we also help to keep the morale of the people high. We also, there's death, there's anxiety, there is fear, mental illness is rising. They say we also play an important role. We do counseling, we offer people spiritual support. We are not able to do so under these conditions. I say, I understand that message. Again, you can't just open indiscriminately the religious establishment without some numbers, without some arrangements, because they can easily just turn into sites of the pandemic. They can just become hotspots. So I do hope that you hear, I'm not wavering on matters of principle, but I am saying check where the pandemic is. When you do adjustment, that's the case we will make as Gauteng. When you do adjustment, take into account where the pandemic is. I think the people of faith have an important case they have made. Those who are in the sector, whose businesses are linked to the sale of alcohol, as business establishments have also done so. We need a balance. We just need to find a balance between those. I was advised that the interns, especially in education, the 400 interns who have not been paid, their payments are going through. regularly. There's a much larger number of interns who have been paid. I was advised now that that glitch occurs from time to time, but I want to apologize to those interns. And these interns are the ones who have been helping us on our program of ensuring that the schools are safe and they are ready. I want to apologize to them on behalf of the provincial government. I know that the Department of Education under MEC Lesufi is resolving these matters. Like we had a situation at some point where the health workers were not paid, including the community, the ComServe were not paid. These things need to be resolved. People work so hard. They need to be resolved. These are some of the technical glitches, inexcusable. They are not excusable. As the head of provincial government, I think it is shameful that we have technical glitches that impact on that. It's shameful when life is lost, like we have had the loss of life of Shonisani at Tembisa. But I know there are many healthcare workers who do their very, very best. And I don't think they should be demoralized when there is one institution and one case that shows that maybe people there needed to have ensure they don't drop the ball. That matter is being addressed by the MEC for Health. Netwerk was not here when we spoke about, they want the breakdown of how many people will be immunized in each phase. I will ask the HOD for Health and the team, communication team from Health, just give them in each phase. Said out of that 10.2 million people, how many will be for the first phase? But with the health care workers group, I think there's a clear number of the frontline healthcare workers in both the public and the private sector. And you know, Gauteng would have the largest number of healthcare workers. Our system is the biggest healthcare system combined, public and private. It's the biggest healthcare system in Africa at a sub-national level in that case. So the information will be communicated, but we targeting to reach 10,000, 10.2 million. Thank you very much for spending the time with us today. Please continue to be safe. The pandemic is not over. And the vaccination program will take much, much longer. We still need you to be safe and do all the necessary things that will help ensure we overcome. Thank you so much.
Okay, we've come to the end of this briefing session. Thank you very much.